Good morning to my moderators. DAPT, dual antiplatelet therapy in ACS, too short or too long. Let us start with the ACCH guidelines of 2024-5. What it says. It actually initial selection of Y2, P2, Y12 inhibitor. They have said in PCI, CABG, non-planned invasive evaluation affirmative therapy in STMI. In all conditions, aspirin, anticoagulant or prasugrel are class 1 indications, except that after fibrinolysis in STMI, clopidogrel may be used is a class 1 indication. And during hospitalization, the oral P2Y12 inhibitors, how it is used. Class 1 indication is that PT in patients with ACS, oral P2Y12 inhibitor should be administered in addition to aspirin to reduce MES. In non-ST-ACS, in non-undergoing PCI, prasugrel who are undergoing PCI, prasugrel ticagrelor is recommended to reduce MES and stent thrombosis. This one is class 1 indication in patients who are managed without planned invasive evaluation. Ticagrelor is recommended to reduce MES. In patient with non-ST-ACS, ticagrelor is recommended to reduce MES when prasugrel ticagrelor not available, cannot be tolerated, or are contraindicated. In hospital management with patients with STMI, the class 1 indications are STMI managed with primary PCI, prasugrel or ticagrelor is used. And in patient with STMI managed with prime PCI, clopidogrel is recommended to reduce MES and stent thrombosis when prasugrel ticagrelor unavailable, cannot be tolerated, or contraindicated. In patients with managed with fibrinolysis, clopidogrel may be used. These are all class 1 indications. And it is ACS. What is the default strategy? Default strategy is DAPT for 12 months. But in cases of reduction of bleeding risk, strategies for post-PCI is discontinuation of aspirin 1 to 3 months with DAPT, aspirin and ticagrelor, but later class 1 indication is continue with ticagrelor monotherapy. Who is getting oral anticoagulant, triple therapy, DAPT, discontinuation of the aspirin 1 to 4 weeks, then continue with clopidogrel monotherapy plus oral anticoagulant. These are class 1 indications, but class 2B indications is that who has got high bleeding risk PCI, post PCI. DAPT is recommended aspirin, ticagrelor or prasugrel, but de-escalation of the P2Y12 inhibitor after 1 month post PCI followed by aspirin and clopidogrel. And DAPT, aspirin, stop aspirin after 1 month, and SAPT, aspirin approach or P2Y12 inhibitor monotherapy, class 2B indications. This is the comparison of ACCH 2025 and ESC 2023. AH and SCC mainly prefers ticagrelor, but ESC mainly prefers prasugrel. But the thing is that the personalized or standard duration of dual antiplatelet therapy after procurement intervention, Parthenov study, a randomized study, what it said. In patient undergoing PCI, a personal DAPT duration from 3 to 24 months based on a clinical score led to lower risk of adverse cleanliness than standard care consisting of 12 months of DAPT. And what master DAPT says, 1 month DAPT duration associated with similar total NAS and MES, but it reduces the risk of bleeding with prolonged DAPT. These findings support the use of abbreviated duration DAPT after PCI in HBR patients. You see, the randomized trial, NAS and MES and major or clinically relevant major bleeding, what is the abbreviated DAPT? MES and NAS are same, but the MCV, major and clinical relevant non-major bleeding, is low in case of abbreviated DAPT. 1 month dual antibiotic therapy followed by procedural monotherapy at reduced dose, that is the 4D ACS randomized trial. What is said? 1 month DAPT followed by procedural 5 mg monotherapy, ACS patients with a drug-coated stent reduced NES by 49%, primarily driven by 77% reduction in bleeding events compared to 12-month DAPT. ESC guidelines for management acute coronary syndrome in patients with ACS 2023 ESC guidelines for the management of ACS recommended default strategy 12-month DAPT with a potent P2Y2 inhibitor is a class 1 indication. However, if the patient undergoes PCI, prasugrel should be used. Corticosteroid should only be used when ticagrelor and prasugrel are contraindicated, not available, or in HBR patients. That is the recommendation, shortening or de-escalation in therapeutic therapy. That is, after 3 to 6 months of DAPT without high ischemic risk, SAPT, the single antiplatelet with P2 inhibitor is recommended is the class 2A indications. De-escalation of antiplatelet in first 30 days of ACS event is not recommended. That is, prolonging antithrombotic therapy, what ESC said. Discontinuation of antiplatelet treatment in patient treated with OAC is recommended after 12 months. That is only class 1 indications. Adding a second antithrombotic agent to aspirin for extended long-term secondary prevention should be considered in patients with high ischemic risk without high bleeding risk. That is 2A class recommendation. These 4 trials, Pegasus, TIMI, 54, DAPT, DESLATE, and OptiDual. The others, and including this trial, said that extended DAPT better than aspirin alone. Is stent type is an issue for DAPT? A SMART DATE trial. This is a randomized coronary stent according to short and prolonged duration of dual antiplatelet pre-specified analysis of the SMART DATE trial. What is said? The risk of composite cardiac death, myocardial infarction, and stent thrombosis is not significantly different between patients receiving bioabsorbable polymer or durable polymer across a short or prolonged duration of DAPT after ACS. What is ultimate DAPT trial said? That ultimate DAPT has 2:2 randomization a study flowchart. There's compared between IVAS ACS RCT, ultimate DAPT RCT. They are randomized and compare with the placebo. There is only trial compared with the placebo. And what is the conclusion? The present result demonstrate that in patients with ACS treated with PCI in contemporary DS who are free from major adverse ischemic or bleeding events after a month on DAPT, treatment ticagrelor alone between 1 to 12 months will decrease clinically relevant and major bleeding while providing similar protection from MES compared to ticagrelor plus aspirin. These results in concept prior warrant updating the guidelines and may change the practice to treat patients with ACS after PCI with 1 month DAPT followed by conversion of CPT with potent P2Y12 inhibitor. A study is the strongest evidence supporting ticagrelor. What is Dr. Stone's comment? These data says that a 12-month duration of DAPT is not only not necessary, he did not say unnecessary, in patients with ACS, but is harmful. There is lack of data as to whether these promising preliminary findings can be translated to high ischemic risk patients, such as those with complex PCI. So, patient-centered approach is best. Individualized antiplatelet therapy after stenting represents an opportunity to balance ischemic and bleeding risk, especially in high-risk patients. Procedural complexity, patient characteristic, and bleeding risk collectively shape the decision-making process of surrounding DAPT. Thank you.